Alright guys, now that you've had a chance to take a break, we're going to pick up with discussing abuse. Abuse is any action or failure to act that results in unreasonable suffering, harm, or misery to a person, whether it is a physical abuse or mental abuse. This can occur to any person, no matter their age, race, gender, or socioeconomical status. Children and the elderly, as well as domestic partners, are some of those that you may see that are abused. According to the National Human Trafficking Resource Center, human trafficking is a form of modern-day slavery in which traffickers use force, fraud, or some type of coercion to control victims for the purpose of engaging in commercial sex acts or labor service against his or her will. Sex trafficking is the recruitment, harboring, transportation, provision, obtaining, patronizing, or soliciting of a person for the purposes of a commercial sex act, in which the commercial sex act is induced by force, fraud, or coercion, or in which the person induced to perform such an act has not attained 18 years of age. Labor trafficking is the recruitment, harboring, transportation, provision, or obtaining of a person for labor services using force, fraud, or coercion for the purposes of subjection to involuntary servitude, peonage, debt bondage, or slavery. Victims tend to not seek help because they may not speak English, have no ID or money, and have no idea where they are because they're moved quite frequently. They also don't have a tendency to speak to anybody because they're afraid of repercussions not only to themselves but to their families as well. Some settings that you might find victims of human trafficking, including massage parlors, prostitution rings and escort services, hotels and nail salons, as domestic labor used for cleaning or child care, elder care, or other services within a home, begging or selling items on the street or door to door, and even in restaurants, bars, or cantinas. These patients will not have the ability to leave. If they are trying to provide any information, they won't be able to, and it'll have to be given by somebody else. They'll have no ID and no possessions. They have no idea of what day it is, what time it is, what city or state in which they're located. They may exhibit feelings of helplessness or guilt, humiliation. They may be addicted to drugs or alcohol, even show evidence of trauma bonding with their trafficker. The victim may also present with signs and symptoms of denial, PTSD, phobias, panic attacks, anxiety, and even depression. Trafficking victims may also present with chronic illnesses such as diabetes, cardiovascular disease that's untreated, STDs, UTIs, pelvic inflammatory disease, as well as genital injuries from sexual assault. As a provider, when dealing with a patient suspected of human trafficking, first thing is ensuring that the scene is safe. Provide any care for the patient as you would per protocol, and transport the patient. If you are unable to transport the patient or the victim, you need to contact local law enforcement, or you can also call the Human Trafficking Hotline with Department of Homeland Security to report suspected human trafficking. If you are able to transport the victim, notify emergency department staff of your suspicion. Document on a separate special reporting form the objective information found at the scene or divulged by the victim or trafficker and evidence of human trafficking found during your assessment. Domestic violence is a term given for any type of physical violence between two people within an intimate relationship. It's a specific type of domestic abuse. In the United States, domestic violence is a leading cause of injury to women between the ages of 15 and 44 years of age. It is also reported 1 in 5 homicides involve murder of an intimate partner. Usually the abuser will isolate their victim, and they tend to either be possibly divorced, disabled, minorities, or even cohabitating with a same-sex partner. The victim is controlled by restricting the person's financial independence and access to money, or the ability to acquire material items such as clothing, medications, and food. The victim may not be allowed to work or may be forced to work and hand over all paychecks. Domestic abuse can come in a variety of different ways. Does not necessarily have to be physical abuse. Even if the victim and the perpetrator is within the same relationship, sexual activity with the victim without consent is domestic abuse. The tension between the victim and abuser increases. The victim continuously does things to please the abuser to reduce tension in the hopes of avoiding the violence. The victim may try to trigger the violence at times to reduce her stress of not knowing when the violence will occur. And it's in a continuating cycle. And that's why for some victims of domestic violence, they're never able to get out. Because the abuser takes advantage of the victim mentally and emotionally to make the victim feel that they can't move on without the abuser there. Once it gets to the point that others are getting involved, the abuser tends to apologize, buying the victim gifts, making the victim feel like, I'm so sorry, I didn't mean to do this. So that way the victim accepts the apology, goes back to the abuser, and the cycle starts all over again. Possible injuries that you might find in a domestic abuse case include abrasions, bruises, burns, dislocations, lacerations, bites, fractures, marks on the neck consistent with strangulation, petechial hemorrhage in the eyes, mouth, and dental areas, genitalia and breast injuries, headache, GI pain and complaints, as well as pelvic pain. You will often find multiple bruises and injuries within various stages of healing. You might also find injuries to the hands or ulnar aspects of the arms indicating defensive posturing. Many calls and scenes in which EMS personnel are injured involve behaviors that are unpredictable and can quickly change. Domestic violence call is a scene that puts you at extreme risk for becoming a victim of violence yourself. If you're ever on the scene, never confront the abuser or the victim of your suspicion of domestic violence. Never allow the abuser or the victim to get between you and the door, because they may get scared and take violence out on you. Because that victim may have feel that without the abuser, they are nothing. They'll never be able to get along or never be able to move on and survive. So if they feel the abuser is going to go to jail, the victim may take it out on you as well. Once you get away from the abuser, if the victim is willing to discuss about it, ask the victim about the abuse. You know, try to put it kind of subtly. Violence against women has become a major issue. Um, I need to know if you've ever been a victim of abuse, whether as a child or an adult. You can also ask them, would you like to talk about it? Have you discussed this with anyone? Are you safe now? Asking these questions will show the victim that you are focused on his or her well-being and his or her needs. You can then pass this information on to the emergency department staff. Additionally, note any of the following, such as the abuser and the victim's behavior at the scene, objectively. Document any other people at the scene, such as children, friend, or neighbor. Also note their behavior and any comments that they may have made. Document the police officers' names and badge numbers, and any referral information or numbers provided to the victim. Your primary responsibility at the scene of a domestic abuse call is to assess and treat the victim for any injuries or illnesses. During your assessment, note any patterns or blunt or penetrating injuries or lacerations, burns, ligature marks, or any other injuries that may be consistent with abuse and violence. Thanks to advances in medical technology, patients are now able to come home on equipment that at one time would keep them stuck in a hospital. This technology can either enhance or sustain their life. Even though you as an EMT have most likely not seen the particular type of equipment found in a person's home, they are expected to be able to troubleshoot it and support any lost function of the patient should the medical device fail. If you ever come up on it to somebody's house that has equipment that you're not familiar with, ask the patient or the caregiver, or usually there's a phone number nearby that we can contact to get information as to troubleshoot that equipment. Do not discount the family or care provider's knowledge of the devices found. They are with this person and that equipment far longer than you are. Thus, they will likely have reliable information on how it works and how the patient responds to it. Although much of the equipment you'll see in patients' homes is similar to what you would see in a hospital setting, there's usually a difference in the size and complexity of the device. Often, the tertiary centers that implant these devices have resources available who can be consulted regarding their care. If at a minimum you provide any care, you'll ensure the patient the best chance for survival, regardless of the immediate emergency and the patient's dependence on medical technology, just by monitoring your A, B, and C. Few problems will arise from medical oxygen systems, and if a problem does arise, it's usually remediated by the patient or primary care providers. Usually the problems that require EMS involve some other type of equipment failure in which the system stops providing oxygen completely. Table 40-2 goes over some of these issues that we might see commonly. Usually we can easily correct this situation, such as faulty tubing or a unit unplugged. Another situation in which EMS might be summoned is if the patient's condition changes or worsens, and the amount of oxygen they receive at home for the chronic condition is no longer sufficient. You may also come across apnea monitors. These are designed to monitor a patient's breathing status And should they stop breathing, it emits a warning signal. It can either be an auditory or tactile stimulation. Some of these also monitor apnea monitors, especially in pediatric patients. When you are summoned to the home of a patient with this type of technology, you should perform your normal scene size up and primary assessment. Because the apnea monitor is designed to signal a respiratory problem, be especially diligent in your assessment of the patient's respiratory rate and tidal volume. If the patient is not breathing adequately, ensure an open airway, provide ventilation, and ensure adequate oxygenation. Pulse oximetry, this can be used at home by patients either with apnea monitors or any type of respiratory issue. If you pull up to a scene and the patient has a pulse ox, still use the one from your truck. Ascertain what interventions have been done, whether the patient has been placed on oxygen, breathing treatments, anything along those lines prior to your arrival. Try to figure out what it is that's going on. A tracheostomy tube is commonly provided for patients who have either long-term upper airway problems or medical conditions that result in long-term dependence on mechanical ventilation. During your assessment of a patient with an emergency pertaining to a tracheostomy tube, you must rapidly determine whether the problem is that of airway occlusion or if the ventilator is malfunctioning, if the patient is ventilator dependent. If the tube is partially or totally occluded due to bleeding or heavy secretions, you want to use a whistle tip or soft suction catheter to clear their airway. Measure the depth of insertion for the suction catheter by comparing it to the tracheostomy tube or obturator. Manipulation of a tracheostomy tube may be outside an EMT's protocol, so make certain that you can perform these interventions before doing so. To suction a tracheostomy tube, you can measure the depth of insertion for the suction catheter by comparing it to the tube obturator. Apply suction, slowly withdrawing the catheter while twisting it between your fingers. If you should happen to go too far, don't fret. You won't harm the patient. You'll know it pretty quickly because they're going to start coughing and jerking a little bit because it's very uncomfortable for them. Once you've withdrawn the catheter all the way out, same premise as you would suctioning a normal patient, you want to rinse the suction catheter with sterile water between each attempt so you don't cause infection. CPAP and BiPAP. CPAP we have already discussed in class, that being continuous positive airway pressure. BiPAP is bilevel positive airway pressure. When there's damage to the lower airway structures from disease, it can be difficult for the airways to remain open. The use of CPAP or BiPAP can help to keep these smaller airways stented open so that better ventilation can be achieved. Emergencies related to a CPAP or BiPAP machine are rare. During your assessment of a patient who uses CPAP or BiPAP machine for sleep apnea, you'll likely learn that EMS was summoned not for an emergency related to the device, but rather for a respiratory distress complaint arising from the patient's chronic pulmonary condition or some other medical emergency. Now the difference between CPAP and BiPAP is CPAP is remember, it's continuous positive airway. So no matter during inhalation or exhalation, it's the same amount of pressure being applied. With BiPAP, they can set the settings differently. So they can have one setting for inhalation and a different setting for exhalation to ensure that the airways stay open. There are two types of mechanical ventilators, negative pressure and positive pressure. Negative pressure ventilators, such as the iron lung, encircle the patient's chest and generates a negative pressure around the thoracic cage. This negative pressure draws the rib cage out which creates a negative intrathoracic pressure that causes air to be drawn into the lungs. These devices are rarely used in the home setting because newer and better technology is available. Settings can include anything from the rate, tidal volume, and even in some cases the amount of oxygen provided. Tidal volume in most devices vents are adjustable, whereas the rate and oxygen supply, if provided, may be either fixed or adjustable. The tubing that goes from the ventilator to the patient is called a ventilator circuit and can attach to the patient's tracheostomy tube if there is one. The ventilator can have a high pressure alarm. This alarm can also be triggered or is activated when the need for lung inflation exceeds the present volume. This alarm can also be triggered by decreased lung compliance, such as the development of a pneumothorax, pneumonia, acute pulmonary edema, or even alveolar collapse. Other causes include a kinked circuit or even a movement of the tracheostomy tube. Whenever a low pressure alarm goes off, this usually means that there's a hole somewhere within the circuit that's allowing the ventilation meant for the patient to be leaked to the atmosphere. Apnea alarms are triggered when the patient's on the vent stops breathing. Because some ventilators what's the word I'm looking for? Assist devices. So they breathe with the patient. So that's what the alarm is for. You can also have a low FiO2 alarm that occurs when the oxygen has become either disconnected or depleted from the ventilator. Also remember, when approaching a patient with a ventilator emergency, be aware that the alarms going off may not have been caused by a ventilator malfunction, but due to a change in the patient's clinical condition. Do not assume that if the ventilator starts to alarm, the remedy is to disconnect it and use a bag valve mask. Although it might seem logical to simply disconnect the ventilator and bag the patient manually, if the inadequate breathing is from a change in the patient's status, such as a pneumothorax, ventilating them manually will provide no more help than the vent could supply. Always troubleshoot the ventilator and the patient. When dealing with a patient that has any kind of airway or respiratory device, you have to remember that they're on this device because of some type of lost function. So you need to ensure that whatever function that that device is supporting, you need to assess its adequacy in doing so, because you're probably going to have to support that once you take them off. As far as your assessment, there won't be any difference. You'll perform your primary, history, and physical in the usual order. Remember that you may need to suction a tracheostomy tube. Patients with vents, you need to troubleshoot both the device and the patient. If the ventilator is providing adequate vents, allow it to continue doing its job. If it is not providing adequate ventilation, remove them from the ventilator and use a bag valve mask device. You may come across patients that have what's called a vascular access device. This can be used for chemotherapy, dialysis. They be in a variety of locations, whether it be on their arm, a port implanted under their thoracic chest, under the skin, in their leg, in their abdomen, wherever it's needed for that device to be placed. Central IV catheters are located into the vein just below the clavicle. Central venous lines is a port secured to the anterior chest just below the clavicle. So instead of a IV that's the central IV catheters are actually sticking out, whereas the central venous line is a port underneath the skin that has to be accessed each time. Sometimes a medication that's needed to manage a patient's condition must be administered often, or because of the drug's action, must be inserted into a large central vein. Placement of a venous access device enables this to be done outside the hospital setting. As I said, they can come in a variety of different places. You can have a PICC line, a port, or a Broviac catheter, a femoral catheter, if a patient has a vascular access device that has an external port for medication administration, always inspect the site for bleeding or infection. Also note the depth of insertion and document this on your PCR. If a problem arises with the depth of insertion, it should be made clear that the EMT was not responsible for causing either withdrawal or deeper insertion of the device. Remember that you are not licensed to access these devices for medication administration. Vagus nerve stimulators, these are devices placed in patients that have seizure disorder. If the patient is actively seizing or feels that they're about to have a seizure, there's a special magnet that they have that passes over the device that triggers it to deliver electrical energy to the central nervous system. If you arrive on scene, if the patient has this type of stimulator, you may need to pass this magnet over the device. Renal failure and dialysis. Acute renal failure is when there's a rapid loss of renal function. This is often reversible if caught early enough. Whereas chronic renal failure, this is a progressive loss of kidney function that can take over months to even years. When the patient goes into chronic renal failure, as it continues to deteriorate, the kidneys will eventually completely shut down to where they are no longer functioning, and now the patient has to be placed on dialysis, where they're basically hooked up to a machine that removes any toxins the kidneys can no longer filter. Hemodialysis, this is when they're actually going to a dialysis center and getting dialyzed. This process can take anywhere from 2 to 5 hours. And this usually occurs approximately 2 to 3 times per week, depending on the amount of time that is needed. If you ever pick up a patient that is at a dialysis center and they are still hooked up to the machine, do not remove them from the dialysis machine. Let the staff there remove the patient from it, because they are properly trained to ensure that the patient is removed safely and secures it afterwards. With peritoneal dialysis, because this form of dialysis is not as effective as hemodialysis, it must be repeated several times a day. However, because of current technology, the procedure is relatively easy for the patient to do without any assistance, and enables the patient greater freedom within daily activities, because they are not bound to making several long appointments a week at a dialysis center. If the patient is a dialysis patient and they have a shunt, you should never attempt to obtain a blood pressure on the extremity with the shunt, fistula, or a graft. The surgical procedures used to create the shunt can be significantly or irreparably damaged by the application and inflation of a blood pressure cuff. Always use an extremity that does not have an AV shunt. The AV shunt, if damaged, can bleed excessively. The bleeding could be external, with significant amounts lost rapidly, or internal, with the formation of a large hematoma beneath the surface of the skin. In either instance, you should apply direct pressure to the site. Management includes keeping the catheter insertion site clean and dry, supporting any lost function that may be present, and transporting the patient to the hospital for evaluation by the receiving physician. Patients who receive their nourishment through a feeding tube are said to be receiving enteral feeding or tube feeding. The device is typically a flexible tube that is long and small in diameter. It is named according to the site of insertion. Feeding tubes can be sent through the nose, in which they are called nasogastric tubes, through the mouth, where they are called orogastric tubes, gastric tubes, where they go through the stomach, and jejunal tubes, where they go through the jejunum. When long-term nutritional support is warranted, a tube may be surgically inserted through the abdominal wall and directly into the GI system. The procedure that places a gastric tube into the abdomen is called a gastrostomy. Ostomy bags. This is a surgical opening through the abdominal wall in which a section of bowel has been removed so that now fecal material is directed outside the body into the bag. This procedure can be done on a temporary or long-term basis and is used in patients with Crohn's disease, ulcerative colitis, colon cancer, or diverticulitis. You can also have urinary tract devices such as a urinary catheter, which is designed to empty the bladder when the patient may have some type of dysfunction to the urinary tract. The least invasive of these is called a Texas catheter or a condom catheter because it attaches to the external male urethra in the same manner as a prophylactic condom would. Foley catheters actually goes through the urethra into the urinary bladder, and a suprapubic is a surgically inserted catheter that goes through the abdominal wall and into the urinary bladder. If the patient has a urinary catheter, it's a good idea to drain the collection bag prior to transport, taking note of the volume of urine removed and any irregularities in color or odor. If your patient does have a Foley catheter, don't pull on it, because whether it's a male or female, that's going to hurt. Just a little FYI. Also, keep it lower than the patient's bladder, so that way it allows gravity to empty the urine out of the bladder through the tubing and into the bag. Patients that have any kind of GI or GU devices, number one issue, if the patient has any issues with where it's obstructed or infected or displaced, don't mess with it. If it's become dislodged, do not attempt to replace it. Just monitor it and transport the patient to the hospital. If during inspection of a GI or GU device it appears the device has shifted or become misplaced, do not attempt to correct the situation. Secure the device in the location in which it was found and transport the patient to the hospital while monitoring the site. Intraventricular shunts is used in patients that may have hydrocephalus, in which CSF is accumulating and not being able to drain properly. This shunt allows the fluid to drain from the brain to a separate area to be relieved properly. This shunt is surgically placed. It originates within a ventricle of the brain and extends to a blood vessel within the neck, heart, pleural space, or the abdomen to drain the excess CSF and keep intracranial pressure at an acceptable level. In some patients, you may also find a reservoir on the side of their skull placed beneath the scalp that collects the excess cerebrospinal fluid for testing purposes. If the shunt drains into an external reservoir, there can be signs of local skin infection where the tube exits the body. In severe cases or in situations in which the patient is immunosuppressed, a local infection involving the shunt can result in a systemic blood infection or sepsis. The obstruction can occur because of the body trying to block off the shunt, because one of the two ends has become dislodged and can no longer allow cerebrospinal fluid to flow out, or there is a physical obstruction within the shunt itself. When this occurs, excess cerebrospinal fluid accumulates within the brain and starts to raise intracranial pressure to potentially dangerous levels. The patient may present with signs and symptoms such as headaches and seizures, increased blood pressure, altered mental status, respiratory depression, um, and even sensory or motor dysfunction. Commonly, the initial complaint seen with intraventricular shunt emergencies is confusion, difficulty with simple tasks, and headaches. As the problem continues, symptoms worsen. When managing these patients, monitor their airways and breathing and ensure that it's adequate. If it's inadequate, provide positive pressure ventilation with oxygen. Terminally ill patients, usually when a patient is termed terminally ill, they usually have less than 6 months to live. The term palliative care is used to describe medical interventions centered on reducing the severity of disease symptoms and providing comfort for the patient. Hospice is the system that is the philosophy of care that is designed to help with palliative care, not only for the patient, but for supporting the family as well through this process. These programs seek to alleviate the symptoms, that manage pain or discomfort, and provide a certain degree of control to the patients and their families during the final stage of life. Although hospice programs primarily work with the elderly, services are also provided to children with terminal diseases. These patients may present with cancer, Alzheimer's, late stages of COPD, congestive heart failure, and cystic fibrosis. It's not uncommon to encounter a hospice patient at the end of life who has accepted that death is imminent, while the family is more frightened or in denial than the patient. Your emotional support to these families can be just as valuable as the palliative care you provide to the patient. You need to communicate with the patient, the family, or the primary care provider about any advance directives that may be in place in the absence of a hospice program. Alright guys, that concludes this chapter. If you have any questions, please be sure to email them to me in Blackboard or send me a message in Remind. Make sure that you are working on your Brady Labs. Otherwise, I will see y'all next time in class. Y'all have a good rest of your day.